we move on to our next speaker, who is Professor Kaisar Nasrullah Khan, who will speak on all the crushes under the sun. He will first speak on how and when DK crush, followed by a brief case-based discussion on mini crush.
Assalamu alaikum and very good afternoon. Really honored to be here. I would like to thank the IPDI team for arranging such a wonderful conference so that we can learn from each other and treat our patients better. Nothing to disclose. DK crush, invented by Zhang and Chen in 2005. It has got basically 4 steps. First crush, first kiss. Second crush, second kiss. So it had got advantage for good apposition to the vessel wall, especially side branch ostium. Now to take you for the juniors through the DK crush steps. First we stent the side branch, keeping 1 to 2 millimeter of the side branch stent in the main vessel. Then we do the first crush. Crush the side branch stent by the balloon inflation at the main branch. Next, wearing the side branch through the proximal cell of the crush stent. Remember, usually we prefer to cross the distal stent for kissing balloon, but DK crush we try to do it through the proximal stent. Then first kiss by keeping 2 balloons, one in the side branch stent, one in the main vessel, and open the start. Next, we do second crush, crushing the side branch stent by the main branch inflation of the main branch stent. And next is spot, proximal optimization technique by a balloon. You have to keep the balloon end in the carina, don't cross the carina. Then again rearing the side branch through proximal cell, and then the second or final kiss by 2 balloons simultaneously in 2 stents. And last step is report. You have to do it report to oppose the stent start with the main vessel, and then took the final picture. The 10 steps of DK crush. Now let's share an example of real life scenario. 25 years old person, ECG echo normal, came to me with angina or exertion. EDT was found strongly positive. So angiogram planned, RCA normal, but you can see the LAD, there is a Mercedes vein sign, left main distal, LAD ostium and sarc ostium. So the rest of the LAD sarc is normal. Syndrome score 1 is 12, 2 is 1.8 mortality in PCI, 0.7 in cabbage. Young patient, so we opted for PCI. As it Medina 111 left main bifurcation lesion, we went up front, double stent strategy, DK crush. So where the both vessels by taking a 7 French guide catheter through radial route, then dilated both lesions with 2.5 and 15 balloon sequentially. Then we took a 2.75 12 stent was placed in the sarc side branch, keeping 1 to 2 millimeter of the stent start in the left main. Remember, you have to keep 1 to 2 millimeter in the left main, because otherwise you can miss the sarc ostium, geographical miss. So be careful about this thing. Keeping a balloon in the main branch, so then sarc stent was deployed, pull back a bit, and then you crush this sarc stent start, which is in the main vessel, 1 to 2 millimeter, by a balloon in the left main to LAD. Then again sarc stent, crush stent was rewired by a BMW. But when we took a picture angiographically, you see it crossed the distal start. So again we pulled back, rewired, and try to do it through proximal stent start. And you can see through this angiogram, it has crossed through the proximal start, though IVAS will confirm it or OCT. Then we did the first kiss, keeping 2 balloons, 1 in stent, 1 in the main vessel. Then angio shot of the first kiss. Then sarc wire was taken out and we put a 3.5 and 33 stent in the left main to LAD main vessel. And while deploying it, we did the second crush, crushing the sarc stent by deploying the first stent in the LF to LAD. Then LCX was again rewired through the BMW wire through the proximal start. Then we did the POT, proximal optimization technique, by 4x15 balloon, keeping the distal end of the balloon within the carina. Don't cross the carina. And again did the second case by 2 balloon in the 2 stents. Then you can see after this good result. Again then report 4x15 balloon, and here also you have to keep the distal end of the balloon in the carina. Don't cross the carina. Report. And this is the final picture. So take home message 1, in 2-stent technique for bifurcational lesion, decay crush technique has the potential of increasing final kissing balloon inflation, good coverage of ostium, and apposition of stent start. Decay crush stenting was associated with significant reduction of ISR, TLR, TVR, but no significant difference in MACE between decay crush versus provisional stenting, proved in decay crush 2 study. 3. Compared to the decay crush technique, classical crush and Coulomb stenting is associated with significantly increased TLR, TVR, MACE in patients with unprotected left main coronary artery bifurcational lesion, proved in decay crush 1 and 3. So last slide, single kiss makes your love warm. Double kiss with crush make it warmer. Thank you.